Yes.
I hope you're well.
Good morning, and thank you for the opportunity.
I hope you're
Good
well.
morning, and thank you for the opportunity. Yeah, I'm fine, thank you.
Great. Okay, so first let's start from, because this is the matter before we even go into the state of the accident and emergency center, and perhaps there's a bigger discussion on the state of Korle-Bu currently. But before we go there, there's a issue of the minister's visit on 21st March.
Okay.
What happened?
Well, like you mentioned in your in the statement that was read, that to the effect that it was staged and that it wasn't reflective of what happens at the emergency center, that is the emergency room. I mean, it has to be said clearly that you cannot stage the emergency room. You cannot tell emergencies not to come. So, well, even the minister said we had information that the minister was coming, but we didn't know the time he was coming. So we were waiting. When we came, we had an engagement. We gave him the briefing, and from there we went straight to the emergency. There's no way you can stage the emergency environment. But if you say keeping the bed sheets intact, those things can be done. But as to the influx of patients, nobody can control it. It's an emergency room. Sometimes you have overwhelming situations. Sometimes you have calm situations. Even when we visited, the place was close to 90% occupied, and we mentioned it there. So as to the fact that we staged the visit to make it look good, it's clearly not in good faith.
You said at the time the place was almost 90% full.
Yes. I mean, we saw it. We visited the red, we visited the yellow ward, we also visited the orange. That is the situation on the ground. And come to touch, let me also mention those who were on the floor are seen in the video. Clearly, I did not say that the video was AI generated. Never. I said we are investigating it. It could be or it might not be. We didn't say clearly that that video seen there was AI generated. And when we visited, when he came, the HOD spoke. The HOD said that at a point they were overwhelmed. They put patients on chairs. And sometimes the patient sitting on chair feels that, well, he's not that comfortable. He wants to lie down. That is possible. So, but this has to also be made clear that they never put, that is not my word. He said that there was no patient they put on the floor to manage. No. So if a patient is on the floor, it could be that after having sat on the chair for some time, they decided to go to the floor. But we as health personnel never, this is not my word, that's what the HOD said, that they never manage patients on the floor. In situations like this, I think that it's good we approach it with the seriousness that it deserves. Like we mentioned that, and that's what we are doing. As much as possible, we try to decongest the emergency room. Not even 200. You can get 1,000 beds there. If you don't manage the situation, it will also get full. And that is why I made mention that majority of the cases are from medical block. We resource the medical block to decongest the place. Some of them are surgical. We move them to the surgical department. That is the only way we can manage the space. As we speak now, we have about 3 consultants there. We had a number of specialists, and the residents are about 20. And that is what we have now. But to say that we also, they also mentioned that the referral system. Certainly, it's good that when they are coming, they let us know. They call beforehand so that we prepare for them. But in certain cases, that is not the case. Before they realize, the patients are coming. The patients are coming. And you cannot turn them away. So, like the HOD mentioned, when the minister came, that their SOP is that maximum 6 hours, they should be able to send the patient to the ward. But sometimes it's able to go up to 24 hours and sometimes 38 hours. And that is the situation we are working to manage.
In a case where it takes up to 24 to 48 hours to send a patient to the ward, what happens?
No, it depends case by case basis. Some of them are very serious. Some of them manageable. So it depends on the case. And also depends on the availability of beds at the ward. And that is just what I said, that we are doing everything possible to ensure that they work within the 6 hours. If that doesn't even work, at least maximum 24 hours, we are able to decongest the place and send them to the various wards that they are supposed to be taken care of. We have also taken a decision that going forward, some of the referrals, instead of going to the emergency, they will go straight to the ward because some of them, the diagnoses are already made clear. It's a diagnosed case and it's being referred from a peripheral area with a known diagnosis. Such cases, we don't need to accommodate them in the emergency room. If it is a medical case, you send the patient to medical block. So that's one of the things we are working on now, to make sure that we keep the emergency room decongested. So I think that this is not the time for us to be doing blame game. We are looking for a solution, not for me, Dr. Adam, and not for the Minister of Health. It's for us all. I can be a patient today, you can also be a patient. So if we say there's a problem, I don't think that is the time we'll be doing the blame game. We should be looking for constructive solutions that will solve the problem. So that is the way I approach it. That is why I mentioned to you our staff strength. Mind you, this emergency and accident and emergency, it's a new department that we created. In the past, we didn't have it. So that is why the number of consultants are not that high. But fortunately, we have a number of residents and senior residents in training. And they all take part in patient care. You see, so let me repeat, we should not go the blame game. I think that we should approach it with constructive ideas on how we resolve the problem.
Doc,
And that is what we are doing.
Listening to you, I get a sense that the only thing you disagree with when it comes to the statement is the portion of the suggestion that it was staged. The minister's visit, what the minister saw was staged. Aside that, you seem to agree with the doctors when they talk about even caring for people in the makeshift situation and also increasing bed capacity, what it could lead to, among others. You seem to agree largely with the issues being raised by the doctors.
That is not the case. I mean, I have told you the situation on the ground. We have beds there. We have procured beds in the wards, surgical and medical. You see, we have a capacity. So certainly, if you don't decongest, it will get full. I also mentioned that we do not take care of patients on the floor. Even go back to that day, no patient was taken care on the floor. Let me put it clearly. No patient was put on the floor. You know, most of them, sometimes when they come, either they are on oxygen or they put in IV lines or whatever. That was not done on the floor. Like I mentioned earlier on, when it's like this, I don't want to go confrontational. I just want to mention the cases as they are. So I still do not say that, do not admit that certainly the space can be bigger. what we have, you cannot even consider it inadequate. We have enough space, but because we have the charging area, we have the red area, we have the yellow ward, and the orange ward. So what is important here is when they come, it's not in inhumane condition. That is not true. You can visit the place. The charging area is not inhumane. You have doctors and nurses receiving the patients, analyzing them, seeing them, and deciding where to send them to.
Mm.
That is in place. Anybody at all can go and have a look at it.
Doc,
It is not in an inhumane condition. Certainly, there are certain things we need to equip the place with, if there are. But
Doc,
I
do you know the
if
Korle-Bu
there's
Doctors
any-
Association?
yeah,
You know them, right?
I know some of them. Yeah.
In fact,
I know them.
you know the chairman, the secretary, you know the treasurer, because these are
Yeah,
the three names that are there.
yeah.
Okay. They are saying, as doctors, that there are situations where, because this is what they say, the issue number 4, occupational hazard, squatting or bending to take care of patient on the floor poses significant trauma. So it means that they have had situations where they have had to do that. If not, they won't put it in their statement. You are saying it has never happened?
Patient on the floor, significant trauma response. Let me say it again. And like I said, we are repeating ourselves. The head of department, when the minister visited, he said, we do not take care of patients on the floor.
But the
And
doctors
that
say
I
they do, Doc.
Well, that's why we are going to engage them. Like I mentioned earlier, I don't want to go confrontational. I think that the best way to resolve this problem is to engage. But the truth has to be said. If at certain times they manage patients on the floor, it has not come to my notice.
Okay.
And that day, the head of department mentioned it. That particular day, the video was taken. No patient was taken care on the floor.
I see. So you're saying that you're going to speak to the doctors about the situation which you are not
No,
aware of?
certainly if they have issues, and we are the management of the hospital, we have to engage them to see how we resolve the problem.
But do they take
That
care of?
is why we are there. If they have, if the emergency doctor has a problem at their place of work, it's for us to fix it.
But do
That's
they
why
take
we
care
are
of
there.
patients in at least plastic chairs or chairs?
I can hear you.
Is it can they do that? Take care of the patients sitting in chairs?
Actually, let me say it again. And I always reference the head of department where he said, sometimes they come, we have situations when all the beds are full. So, or maybe they come to charging, there's somebody already on the bed. You sit on the chair, they'll try the patient, then they'll decide where they are sending the patient to. So I cannot say that because that when you go there, you see chairs. And sometimes when the patients come, we put them on the chairs, they sit on the chairs, we review them. When we want to admit, then we move them on, either to yellow, depending on the taste, or to orange, or to red, or sometimes immediately to the wall. So I'm not denying that there are chairs there. There are chairs there where we keep patients, but transit, not on long-term basis. Yeah.
Mm. Then there's also the issue of course, is something that you reference that the no bed syndrome is more complex than the availability of space. The provision of 1,000 extra beds would not immediately translate into enough health personnel to take care of the patients. They are also talking about the health personnel they have currently is only capable of taking care of the situation now. That if you add 1,000 beds, it means that you have to employ more. Do you agree?
Okay. I mentioned it earlier that if you don't manage the space, keeping patients within 6 hours, maximum 24 hours, they move. Even if you have 1,000 beds there, it will not solve your problem. That we are working on that, and that is their SOP they are trying to achieve. Sometimes it might be difficult, but they are working as much as possible to achieve that. We have a country. It's not only Korle-Bu that we have. We have other hospitals in Accra, and I also mentioned it. Sometimes patients are referred without even prior notice. I think that's what they are talking of. And they are also talking of probably how we can resource the other hospitals to manage some of the emergencies. But when it comes to staff strength, I mentioned it to you. Currently, our staff strength, we have a particular number of consultants, about 3. We also have senior residents, we have specialists, and we also have junior residents. So to increase the number of staff for now, except we are going to employ consultants who are not Korle-Bu staff. The intake of residents is time-bound. We take in September, and sometimes we take in April. And now, I mentioned earlier that we have residents about 20. We are in which month? We are in March and then to April. So if there's going to be any intake, we can have residents again. So residents come in September, generally. So until that time, we are not expecting any more residents. So that is for Korle-Bu. And that is what I can speak to. What happens at Rich Hospital? What happens at UGMC? What happens at Bank Hospital? I don't need their staff strength. But what would be good is, before the cases are referred, and the minister mentioned it, and employ all medical staff, stabilize the patient, give a prior information, and send the case. If we have situations like that, some of them might not even end up in the emergency room. As they come, we send them straight to surgical ward if it's a surgical case, or we send them straight to medical ward if it's a medical case. If it is an eye case, you send them to eye department. If it is a plastic case, you send to Ben's unit. So that is the way we manage it. Let me repeat. Situations like this, I think that press statements, press conferences will not solve the problem. We have to engage, constructive engagement, and see how we resolve the problem. And that is why I mentioned that we will keep engaging them and see how best we can resolve the problem. Certainly, Korle-Bu alone cannot resolve all the medical emergency issues in this country. So that is why other hospitals need to be resourced. And you cannot resource a hospital overnight. That's just what I mentioned to you. There are intakes, those who are residents, and they form majority of the frontline workers. I also mentioned the number of consultants. There are few. And the senior residents or the specialists and the senior residents, there are also not many. That you cannot immediately change. So what we are doing, when it comes to staffing, we are not in that situation.
Okay.
But as much as possible, we are working to increase our number of consultants. And that is not all. The residents, the consultant, the specialists, or have a duty when you are on call. That when patients come, no matter what, you see them as a doctor, which we have shown old faith, and take good care of them. You do your best, and the rest is with God. When we are taking care of patients, it doesn't mean that no patient will die. But there are situations you do your best, but you still lose the patient. But that is not to say that what I want to hammer is our doctors, which they are doing their best to make sure that when these patients come, we receive them in dignity, take care of them in dignity, And either we are discharging them or moving them to another ward, that is also done in dignity. We have made an ambulance on standby. That is, if they are referred or sending a case to the medical ward, the ambulance comes in, take the patient in there, and move the patient to medical ward, to surgical ward, to Ben's ward. So this is a dynamic situation. It keeps changing. And you can never predict the state at any time. Sometimes it's overwhelming, sometimes it's manageable. But that's why it's called an emergency. You never know when an accident will happen and the place will be overwhelmed. And sometimes too, the place is quiet. So this is a place that you are ready for anything. So that is why I mentioned that we have to keep engaging them, knowing what the tools they need to work so that we can resource them and make sure that when patients come, they are taken care of.
Now, let me conclude by asking you what the state of Korle-Bu is.
What
is the current state of Korle-Bu?
Korle-Bu is, let me say, is in a fantastic state.
Fantastic.
But that is not to say that we don't have problems.
It's in a fantastic state.
In a fantastic state, but we are dealing with the current situation we are trying to manage. So the question you ask, you know it better than me. So
the choice, the word you've chosen to describe Korle-Bu is what is when you call it fantastic.
No, like I'm saying, you asked me the current state.
Yes.
The current state is not bad.
It's not bad.
I cannot say it's in a perfect situation.
Okay.
I cannot say it's a perfect situation. That's why I said it's a dynamic thing. Things keep changing. And mindful of the fact that this is a hospital which is over 100 years old. So there are certain infrastructure issues that are certain, but when it comes to equipment, we are making sure that we have all the available equipment to work with. I have engaged almost all the departments. And my first message to them is always that let's resource the hospital. You can't be dealing with structures when you don't have the basic tools to manage the patient. So our first priority, our first mandate as a hospital is patient care. And it has to be reflective of what is happening anywhere in this world. It's also a training institution, and we also promote a lot of research. So that is the institution we are dealing with. But how do you do it? If you are taking care of patients, if you are conducting research, if you are training, the condition has to be up the task. You need to have a conducive facility to facilitate the training, to facilitate clinical care, and also to encourage the conduction of research. So that is the situation in which we are now.
Thank you. Thank you for speaking to us, Doc.
Yeah, thank you, sir. It's my pleasure. Yeah.
Dr. Yakubu Seidu Adam, CEO Korle-Bu Teaching Hospital, speaking to us on a few things, that video, and also on the matter of the statement that has been issued by the doctors at the Korle-Bu Teaching Hospital, who are raising concerns about the current situation under which they work at the Accident and Emergency Center. Doc says, the CEO says, it's a dynamic situation. Some days it's overcrowded. Some days there's calm on the front. You can do up to 90%. That on the day the health minister visited, the place was full to 90%. So 90% of the capacity had been taken up. So clearly they were managing when the health minister came there. But that doesn't mean it wasn't. He said it was not staged. It cannot be said that they staged anything. That is how the place is. Some days it is clear. Some days it is full, and sometimes full beyond capacity. But he says he's never heard of a situation where they had to take care of a patient on the floor. Now that he's heard about it, he'll speak to the doctors and engage with them to understand the under the circumstances under which some of those things have happened. Well, we are still talking about emergency healthcare, but like the doctor